Hello, today we are demonstrating the cooled radiofrequency ablation technique of the knee. As we know, knee osteoarthritis is a very significant complaint in older Americans today, and this procedure provides us with a non-surgical technique of providing pain relief. Unfortunately, not everyone is a surgical candidate. They are too young, they have comorbidities, they might be too heavy, or the patient is just not interested in surgery at this time. Thus, this perhaps gives them an opportunity to have pain relief. In the knee, there are 6 articular nerves, which we call geniculate nerves. 3 on the lateral aspect of the knee, coming down here, and 3 on the medial aspect of the knee. The medial knee articulate nerves are supplied from the tibial nerve, while the 3 geniculate nerves on the lateral aspect are supplied from the common peroneal. The 3 that we have decided, based on the Rivera article of 2010, to block and then burn would be the superior lateral, superior medial, and the inferior medial. And the rationale behind burning these three particular articulate nerves are the very reproducible anatomical connections between the shaft and the epicondyle of the femur and the shaft and the epicondyle of the tibia, where these geniculate nerves are found with quite a bit of precision. In my practice, I block the 3 geniculate nerves. Personally, I use 2 cc's of 0.25% bupivacaine, and I am looking for greater than 50% relief for approximately 24 hours. If that patient has good results, then I go forward with the cooled radiofrequency ablation procedure, which we are demonstrating today. With the procedure, again, starting with the superior lateral geniculate nerve, I am marking here the connection between the shaft of the femur and the epicondyle. I will anesthetize this region and place my cooled radiofrequency ablation introducer. I then guide this to the bone, trying to be in the notch, again, between the shaft of the femur and the epicondyle on the lateral side. I have found bone at this particular moment of the femur, and I will gently slide past that, again trying to stay in the region of the knot. I am periosteal at this point to approximately 50%, which we'll demonstrate on lateral. My attention then turns to the superior medial geniculate nerve. I tend to anesthetize and place my introducer needle just off of the bone so that I may guide with a very slight angle my introducer to the femur, trying to find the notch between the femur and the epicondyle. I am on bone at this time, making small adjustments as I slide periosteal at this point as such. Finally, attention is turned to the inferior medial geniculate nerve. I've identified proper placement at this level. Place my introducer needle. I have contacted the tibial shaft. I will slide my needle periosteal on the notch of the epicondyle and the tibia. At this point, I will roll lateral and make fine adjustments. So for our lesions, we would like our lesion to be at approximately 50% of the diaphysis. Therefore, with fine adjustments, again, staying periosteal on the femur in these particular nerves, I'm going to withdraw to that particular position. And for our inferior medial geniculate nerve, we have made fine adjustments for our needle as such. I would save that image and then roll AP. Take our cooled radiofrequency ablation introducer, place it on our probe. So on AP image, I check the placement of my introducer in the probe, which again remains at the notch of the shaft and the epicondyle. At this stage, I would like to test with 2 hertz and 2 volts to make sure I do not have motor stimulation. If I do not have motor stimulation, I pre-burn place personally 1 cc of 2% lidocaine to try to minimize post-procedure pain. Once that needle has then burned for 2 minutes and 30 seconds at 60 degrees centigrade, I repeat the procedure on the other 2 needles. Again, doing motor check, 2 hertz and 2 volts for me personally, 1 cc of 2% lidocaine after I have not demonstrated any motor stimulation, and a burn for 60 degrees centigrade for 2 minutes and 30 seconds. This would then complete the geniculate nerve cooled radiofrequency ablation of the knee. Thank you.